and our CBO partners. And as you can see from this slide, we have a broad array of participants that we work with, from nursing homes to community-based organizations to population health, behavioral health providers, and of course the 2 academic medical centers in our community. One of the most important things I think you can see from this slide is that nearly 4 in 10 members of the community of Staten Island are affected by DSRIP. So our breadth and scope of what we are trying to accomplish with our partners is extremely important to the population health of this community. And to be effective and really reach our goals, we know that the social determinants of health are absolutely critical, and everything we do in terms of our analytics really incorporates these variables that we've obtained from a number of different sources, and we'll focus on these as you hear from our healthcare information technology team. But what I want to emphasize here is that it is important to look outside the traditional scope of the health data that we are comfortable with and begin to focus on information that allows us to expand our review of how these elements can be incorporated into the project as they're being implemented. And in terms of projects, we are working on 11 of the projects here. We have no governmental hospitals, so we're also doing the patient activation Project 11 or 2DI. Another way of looking at this distribution, of course, is the domains of the service that we provide. So it really is across the whole community of health elements. We have behavioral health, long-term care, primary care, care transitions, and the infrastructure projects that will create the durable platform for healthcare delivery of the future. Another way to look at this more focused with the lens of health information technology and analysis is how these 11 projects are categorized in terms of their domains and how those domains are translated into measures. And ultimately, being an individual that has a great focus on performance improvement and quality assurance, we know that measurement is the key to performance enhancement. And rapid cycle change is something that is absolutely paramount when working with so many different providers from so many different domains who have different bandwidths in terms of their capability to create measures, to functionally integrate those into their operational teams. So we recognize that our support in assisting them is absolutely critical. And as we talk a little bit more about rapid cycle change, and we'll get into this further later in terms of the use cases, I want you to take a look at this illustration that we have that demonstrates that our focus on receiving data from our partners has really sharpened from the early stages back in May when the PPS began up until this point. We request that in the majority of our projects, participants send us actively engaged and other performance data twice per month. Now, this is something that we talked about at the PAOP, is an evolving process, but the focus here being that if you look at the work that you're doing in terms of caring for the populations that you're managing, that you really do need to know on a regular basis and use this information as business intelligence. And when you do that and you're focusing on your performance continually, you really are able to hone down and identify opportunities to create more efficacious delivery of services. And this ultimately will lead to a better population health outcomes. So this really is something in terms of our goals is a tremendously important component, and we've seen a great uptick in terms of individual organizations' ability to meet these goals, and we're very happy that it is being incorporated into the day-to-day execution of their projects. So I'm going to turn the mic over now to Annie Chen, our Senior Director of Health Information Technology and Analytics. She's going to take you through the infrastructure portion of the presentation. And when she's finished, we're going to come back and go through some of the illustrations around hotspotting, geomapping, and then our colleague Vitaly Druker will go through some of the technology aspects of the database and how the measurement platform works. Annie?
Thank you, Joe. So being a new code PPS, we need a unified platform that are scalable, efficient, robust, and can consume large amount of data near real time to help the PMO office manage 11 different district projects and address their unique IT needs. So we like to demonstrate how analytics can help in program development, performance monitoring, and program administration. And this is really thinking about the data in a different way, not just thinking about your EHR data as your clinical or financial data as just billing and cost, but rather how to correlate the different type of data and sources to answer questions and meet district goals. The Staten PPS provides the following 4 sets of IT services to our partners. For data warehouse and analytics, we use claims data sets and direct data feeds from our partners to build longitudinal patient records. And we develop risk stratification algorithms to proactively manage at-risk populations, generate reutilization reports, and create disease-based patient registries. We also connect our partners with RIO for bidirectional data sharing, healthcare information exchange, and help our partners set up care alerts, secure messaging to achieve interoperability across the integrated delivery system. On the partner and patient engagement aspect, we provided training and learning platform, help the partner build a care management coordination process, and piloted telehealth projects and provided level dashboard to monitor their performances. Other IT functions within our PMO office include reporting to both our providers and PPS partners. There are various data management efforts and needs happening at the state, PPS, and partner level. At the state level, statewide MPI, MAP dashboard, and Medicaid data warehouses are made available to the PPSs. Within our PPS, the data team is building a clinical data warehouse that will be used for performance reporting and data analytics. At our partner side, they also need to invest in EMRs and other electronic platforms in order to meet various district milestones. So this slide shows various analytics tools that's either developed internally or externally Staten Island PPS uses for strategic planning, performance improvement, and population health management. On the upper left-hand side corner is the MAP dashboard tool that allows us to benchmark ourselves with our peers. In the upper right-hand side, it is the healthcare hotspotting application that we developed here to direct programmatic work efforts, which we will be presenting 2 use cases later in the presentation. And the bottom is the performance management dashboard. Here we are presenting 2 views. One view is the executive view. The other view next to it is the analyst view with the capability of drill down to the patient level detail. They are 5 building blocks for us to build our IT platforms. From the bottom to the top, the first building block is to build the enterprise data warehouse, taking disparate data sources, normalize it. And the second layer is to build the business logic for measure calculation and reporting metrics. We are also building a self-service performance improvement dashboard and visualization tools that allows the analysts and executive sponsors to measure performance. This slide shows the current and future state of our IT infrastructure. On your right-hand side is the internal reporting platform. We have a local server that's sitting within our office. After the opt-out process, we are migrating our infrastructure into a secure cloud-based hosting website. The backend will be hosted by the Azure cloud, and this cloud-based solution talks to the map tool, and also it connects to the RIO for healthcare information exchange. We highlighted a couple of data sources across projects and how we utilize the data source to help build a different roadmap for us. For example, at the bottom, we're looking at data sources 1, which is the Department of Health member roster, 5, that is the actively engaged member roster from SI-PPS partner, 7, 8, and 9, which are direct data feeds from our academic medical center and health home partners. Using these 5 different sources, we're trying to build a patient-based cohort registry to satisfy 5 different projects. The first project is the diabetes management. The second project would be health home at risk. We're also trying to manage care transition to reduce 30-day readmission and integration of palliative care into nursing homes, and the last one would be the Interact project. This slide demonstrates that in addition to working with direct data feeds from the partners and Department of Health data sources, we're also working with public data sets. For example, the uninsured population and planning Department of Health data and New York State Fitness GRIM. And now I will turn to my colleague, Vitaly Drucker.
Thank you, Annie. Supporting all of the data that Annie just described is a robust security infrastructure. We are being guided in fulfilling the security requirements by some of the workbooks that DOH has asked us to complete in order to receive the actual data. I'll be touching on those in the next slide, but just to focus on 2 main parts of security that we find especially important is data encryption and identity authentication. So data encryption refers to both the data at rest and as it's being transmitted, and it's important for the identity assurance aspect of it to include 2-factor authentication. So I'm sure many of you are familiar with the set of security workbooks that are outlined here, and besides identity assurance and the systems and communications protections workbooks, which I kind of just touched on, we have 3 other full sets that we are working to complete. 2 have been submitted to DOH, and the 3rd set is due at the end of April, and we'll be completing that shortly. And now that the foundation is laid for all of the data, we know that there are a number of issues and challenges that we might begin to face for the external implementation. Some of these challenges are outlined below on the left. For example, we know that our PPS partners are in various stages of having their own IT infrastructure. In order to actually get data from them and to work with them, we need to make sure that they are all up to speed and have state-of-the-art EHR and other electronic data systems. Another issue for actually using the data is how we're actually going to manage consent in order to get data from either the partners or from the RIO itself. And lastly, we understand that some state proposed solutions may not work in our specific instance, and it's vital that we move forward and chart our own course whenever we can in order to move quickly and complete DSRIP goals. To this end, and to the first issue I brought up, one of the first things that we did as we started DSRIP was to complete the IT assessment. And you can see a little sample of it here. We focused on a number of different areas for the IT assessment. The ones that you see here are the RIO connectivity and the EHR adoption piece. The bubbles here each represent an individual partner in our PPS, with the size of the bubble directly relating to the number of projects that they're in. So visualization like this helped us understand that our primary care partners and our hospital partners, which are shown in purple and green respectively, are doing pretty well, definitely in terms of RIO connectivity and in EHR adoption, but there is a large group of the smaller partners that we need to really focus and spend our time on.
Thank you, Vitaly. I want to focus now on some material that I think is extremely important for the PPS partners throughout the state to recognize, and that is the population health management is the key to success in this initiative. And there are really 5 data points for population health management that we're focusing on. You can see them here. And certainly, from the standpoint of execution, having data is important, having business intelligence is even more important, but the culmination of all of this is integrating this and engaging with partners and local governmental units, public officials, to really drive change in the population health platform and looking at the efforts of how these initiatives are developing. To that end, we have invested a great deal of energy and time in creating population-based disease registries around the specific projects that we are working on, and ultimately with the goals of reduced emergency room utilization, avoidable hospitalizations, and preventable readmissions. These are the foundation of reaching those goals. We have population health data points that we use for delivering culturally competent programs in the community, and we recognize that using data visualization and analyzing claims data and other variables we were able to bring in from various data sources that conditions like asthma and obesity, in addition to some of our specific 11 projects like diabetes and opioid abuse, are very much related to the conditions that drive people towards the hospital, but are very much ambulatory sensitive and can be managed more effectively in physician offices. So we have spent a great deal of time using our tools, and you'll see some of them in these next few slides, on where to focus the resources that we have available, where we should be focusing on identifying community-based organization partners to specifically focus on those conditions. And in these 2 slides, you'll see on the right first the asthma case, where we can see in the North Shore of Staten Island along those top 5 zip codes, there is a large number and heavy hotspotting of asthma as a condition, and by bringing in various variables, we are able to identify so that culturally competent care can be created and then presented to this population, their backgrounds, their age, their sex, and the number of distributions also around the partners that we have in those communities already, so we can use it to focus on where we need to bring new partners into the PPS. And the same for the map on the left, which is for the diabetes slide in the population from 19 to 64 years of age. Again, bringing in these different variables allows really good focus on resources and partner identification. Here's a slide that we're able to develop with information from the New York City Fitness Gram. This is for obesity in the K through 8 subset of students attending public schools throughout Staten Island. And again, this data, the way we receive it, is split into the 3 Staten Island, but again, it allows us with the other data that we have to identify where the most severe aspects of the problem are, and then focus on those communities so that we can bring those efforts to bear, not only in the schools, but partnering with community-based organizations and identifying physician practices to bring into a population health improvement program where they are incentivized to a value-based purchasing model to alleviate this problem in their community. One of the pernicious problems we're dealing with on Staten Island, and it certainly is a problem throughout New York State, is opioid dependence. And again, this slide brings in information from a number of different sources. We're able to categorize and hotspot and geomap where the problems are, the age, the sex, the race, and the concentrations in these communities so that we can, again, likewise, drive change and really make an impact in this population. So you can see we X'd out the number of total claims. We can also see the number of total claims as well as the number of unique Medicaid claimants per geographic area. I'm going to move very quickly through this next slide, but this is a very exciting initiative we're working on with the Mayor's Office and with Greater New York and the folks from FDNY and EMS, and that is super utilizers, individuals who utilize EMS services multiple times throughout the year. This is a small subset. We're actually working on now 2014 and 2015 data from both of the hospitals, and we've shared the data set with the FDNY, so we'll have a full, complete review of what the super utilizer status is. But you can see, just quickly looking at this, that there are individuals that have called EMS over 30 times per year, and this small subset, the average number of calls is 10. We can break it down by the shift of the call, by the day of the week, and most important here, of course, to focus on is the majority of these are really not acute care calls. Mostly they're related to alcohol intoxication, some behavioral health conditions, and in some instances there's really no pronounced acute medical problem, as you can see on the right-hand side, 19% of the time. So, you know, I think from the perspective of EMS, this will allow patients to receive services that they need in the setting that's most appropriate, avoid individuals going to the emergency room, and certainly from the perspective of those who are in need of EMS care that truly is acute heart attack, stroke, motor vehicle accidents, and the like, to get services there faster. And this geomapping takes us down past the zip code level, and these are the actual addresses of individuals and the locations where these calls were responded to by EMS. So as you can see, we're really able to take data down to a very refined level and allow us to move very quickly into strategic planning and development of strategies around how we can engage community-based partners and our clinical partners in the community to be more effective in terms of services. I'm now going to turn it back to Annie Chen, who's going to be focusing on the performance improvement platform.
Thank you, Joe. The slide here shows that the variety of measures that we've included in our performance dashboard. So in addition to the Department of Health DSRIP measures, we are also creating new metrics, mostly surrounding the population health management area. Our performance dashboard is role-based. Each user has the access to the information they need. So there are 4 different types of roles. There are clinical committee executives. For giving this role, the user are able to look at the enterprise-wide performance scorecard for DSRIP projects. If you are a provider executive, you will also be provided a performance scorecard view. However, it's only tailored to your organization. And at the bottom left, there is a project team lead role that is enabled the project lead to look at the project level performance scorecard. On the right-hand side, at the lower bottom, we have an analyst role that has the capability of drill down to patient level details.
And so I want to just show again the dashboard that Annie brought up in one of the earlier slides. This is you can see it a little bit more clearly here, and it shows really what Annie just described about the different types of roles and the different types of information that's available to those roles. So the executive role, you can see, has a very high-level view, and there's no actual patient information in there, which helps with security and also paints a clearer picture, while the informaticist role gives a lot more details, but you know, there's more security that's involved with that role. And this is another view of a very similar dashboard, a little bit more condensed, still at the very high level. And this is obviously with not real data, but we're looking to fill it out very quickly, and we should have it up and running very soon.
Okay, so right on schedule, we're at the last slide. We want to cover a couple of key takeaways here, and then we will field some questions that are being sent in electronically. And because of the large number of participants, I don't believe we're going to be able to have an open call session, but we will be working with the department to respond to people's questions individually and send that information back and allow the department to synthesize some information and also circulate that as well. But in terms of key takeaways, health data is rich but information poor. Analytics are absolutely essential to turning this health data into business intelligence so that it's actionable and can be turned into an executable program. Diverse IT capabilities of the partners requires an innovative strategy to bring everybody into a space where that they can be effective in program execution. The plan for IT adoption will vary by provider type and role, and the support that we need to give providers is going to be a variable as well. Everyone needs prompt feedback in terms of performance improvement, and this is really something that we've seen as being very successful in allowing our partners to meet their actively engaged targets. Partners will need to make some IT investments in order to reach the goals of Rio connectivity and being able to exchange health information across the continuum. And their project management focus is on facilitating data aggregation, real-time measures, calculation, and population health. I really do want to focus on those last couple of things. In closing, real-time measures calculation is extremely important. Being able to identify where improvement needs to be targeted and where success is really very evident, so best practices can be shared, is very, very important. And this is not just simply about data management. We live in the community for the population we serve, and we want to make an impact in improving their health, and being able to have access through our real-time data feeds allows us to really make a difference in this population and not have to rely on dated claims data that could be a year old and incomplete and potentially inaccurate. So by being a little bit more creative and innovative about data acquisition, I think we've allowed our partners the capability to tailor their programs and allow the PMO office to provide good direction and the supervision to that effort. I think we're going to close now. I don't know if Peggy or Brooke would like to make any closing comments, and then we'll do our best to manage some questions. Thank you.
Oh, I'm sorry. I was on mute. I was talking to myself there. I just wanted to thank you. Just really wanted to thank you, Joe, and the Staten Island PPS team for your presentation. I think it was very impressive, and it really shows taking DSRIP, really to heart as far as how really thinking outside the box, really being very creative around how you can make use of what is available, and really taking it to the local level, involving everyone, including all the data that is out there, because there are a lot of data sources out there, and it is a matter of how do you match these and make them actionable. So thank you very much. So with that, I think we'll just people can type in their questions. I think you've got some questions already, So I'll turn it back over to you.
Thank you, Peggy. So we have a couple of questions that we will respond to. One question is, was the information related to EMS that we looked at Medicaid only? And the answer is yes. Another question is the SI-PPS receiving any data from the RIO that we're leveraging for analytics? And we are not receiving any data right now from the RIO, but we are expecting that that will begin in April. Our focus right now has been connecting our partners, and we are also looking at the important factor of event notification with the RIO as being one of our primary drivers of value there. I think when individuals hit the emergency room or are hospitalized and the primary provider is not aware of it, this is definitely something that we want to prioritize. In terms of the question about EMS, the EMS data was provided from Richmond University Medical Center. That is one of the parent organizations from the Staten Island PPS. There's another question about infrastructure components. So Annie, I don't know if you'd like to tackle that. So I'll read the question. Were any of the infrastructure components, the data warehouse performance dashboard of the Staten Island Central IT system, derived from existing deployments, or did SI-PPS have to newly procure all components?
So SI-PPS builds the enterprise data warehouse from ground up. So we are taking the direct data feeds from our two parent hospitals as well as the GSI, and we build the infrastructure.
And we do have an information technology partner that has created the cloud-based platform for us and works with us to create the visualization and the quality analytic platform as well. There's a question about accessing the recorded presentation at a later date. The Department of Health is going to manage that, and this will be posted, I believe, by Monday. The PowerPoint presentation, likewise, will be available through the department posting that. There's also a question regarding our strategy for ascertaining security requirements in the workbooks and how they are met by our providers. Vitaly and Annie, I'll ask you to field that question.
Yeah, so we are working to kind of distill down the workbooks into slightly more digestible requirements for our providers, and we are working with them as we actually begin to transfer data to make sure that they fulfill the key requirements that the security workbooks require.
I think the other thing that is important to recognize is that the PPS spends a great deal of time in the field with our providers. So before information are shared with individuals, we make sure that we do have confidentiality agreements in place, that there are compliance information being exchanged with the organizations, and that they understand the requirements around patient confidentiality and PHI. And this certainly extends out to how we managed information about the registries being provided to us. Maybe you want to talk about secure file transfer and things like that as well.
So for our direct data feeds, we are establishing secure data transfer between our two parent hospitals to ensure the data in transit is secure. And also at the data at rest, we're also compliant with the Assure secure protocols.
Training.
We have another question. How is the PPS handling the issue of authorization to share PHI data? Has the PPS determined that the DOH opt-out methodology can be interpreted as an authorization to share data? You know, I think that we are all still waiting on the conclusion of the opt-out period, but in terms of sharing PHI data, there is no re-release of data between partners, so we receive data from individuals that contains PHI, but when we are working with our partners in committee or individual setting, if we are not sharing with them information that is theirs alone, then everything is de-identified. So until we have some further clarification and completion of the opt-out process, that is how we're managing that. Another question is, how has the data initiative been resourced between external contractors, the PPS, and partners? So if you mean by the data initiative, of course, that I think needs to be broken down in multiple views, right? We have an IT partner that has brought a great deal of acumen to developing the infrastructure and working with us on a lot of the technology elements. And then within the organization, in terms of analytics and supporting the providers and being able to drive performance improvement, that has been more of an internally driven process that takes place with our clinical team, the chief medical officer, our nursing consultants, and our project directors. And I think, and I should add to this, when it comes to the partner piece, especially as it relates to the health home, we are using the health home here on Staten Island to help drive the health home at risk along with our partners from Northwell. You know, the partners, when it comes to the Health Home at Risk project, really do have great capability to provide information about their clients, the care management plans, and then we are working then on this side to identify and flag when individuals are hospitalized or are receiving services in the emergency room, again, in that kind of registry approach, so we can evaluate the effectiveness and share that information between the organizations. All right. I think at this point we've covered the questions that I could see. If there is anybody else who would like to pose anything, we do have a couple of more minutes before we are scheduled to complete. All right. I think we have essentially answered the questions that were posed. Peggy, anything you would like to mention in closing before we sign off?
Well, again, I wanted to thank you, Joe, and the team. And I think obviously you and the team are available for any further questions, and there goes your website. Exactly. So those are the folks to contact if there's questions that occur to everyone. You know, after this webinar, we will be posting this, making it available. And, you know, again, I think it's great work on the part of the Staten Island PPS. You know, data, you know, a really good point that, Joe, that you made around you're going to be data rich with information for. A lot of this is at least pointing you in the direction where, you know, then people who may have much more detailed level data, perhaps at the patient level, to then further explore, you know, how the kinds of interventions that would happen at that Medicaid member level. So this is great work.
Thanks very much, and I appreciate everybody on the IT team at the department for organizing this and working with us to get this put together, Peggy. Thank you.
Well, thank you. So with that, we hope everybody has a great weekend, and look forward to you know, any further discussions on this. Thanks again.
Perfect. Thank you. Bye-bye.
Bye.